So a very good morning to everyone. I, Dr. Poonam Joshi, welcome you all to our Head and Neck ACTREC academic classes. Our today's class is by Dr. Sarbani Ghosh Laskar, Madam, and this is a class on the topic management of distant metastasis for head and neck cancers. Actually, Dr. Sarbani, Madam, is trying to join. There is some issue with the joining. She will be joining in 2-3 minutes. Just wait for that. We'll be starting in 2-3 minutes. Madam, good morning. Madam, we can start if you are okay, Madam. Sarbani, Madam. Hello. Madam, you can unmute yourself. Sarbani, Madam.
Sorry for the delay. Sorry for the delay and good morning, everybody. I'll just quickly share my slides. Completely. Can you see my slides?
Yes, Madam, we can see.
I'm very sorry for this delay because of some parallel commitment. So let's get started with this topic, and please understand that what I will be presenting today is in large actually a brief overview of the concepts that we have in the management of distant metastasis for head and neck cancers. So about 4 to 24% of head and neck cancers develop metastatic disease eventually. Around 10% of these are de novo and 30% are metachronous. Usually a function of the site, stage, and association with various viral etiologies. And the reason I'm talking about viral etiologies is that the HPV positive oropharyngeal cancers or the EBV positive nasopharyngeal cancers have a different pattern of distant metastasis, which is very different from other head and neck sites. So this is something that you have to understand. Now, the most common site of metastasis, of course, is the lung, bone, followed by the liver. Common head and neck primaries associated with distant metastasis are usually the local regionally advanced hypopharyngeal cancers, nasopharyngeal cancers, HPV-associated oropharyngeal cancers, and thyroid malignancies. It usually coincides or follows locoregional failure. Hence, if you see, most of us would say that it is very unusual to find metastasis if the disease is locoregionally controlled. But over the years, we have realized that there are certain tumors that would fail without any failure at the locoregional site also. So there are certain common terminologies that all of us have to understand, and these common terminologies actually extend to the fact that we need to understand the extent of the disease. We need to understand how these metastases have come up in relation to time. So based on the extent of the lesion, you could divide them into polymetastasis, which mean this is widespread metastasis, versus oligometastasis, which classically has been defined as less than 5 metastasis. Based on the timing or development of the metastasis, that means they could be together at the time of diagnosis of the index cancer itself, or it could be metastasis, a metachronous, which means typically after the primary has been diagnosed. And the usual definition is 6 months, but the UICC AGCC may also in some cases consider it as less as 4 months. And then there is oligoprogression, that is the progression of limited number of sites after completion of systemic treatment. And this in a sense can be linked to the heterogeneity of the tumor and progression at certain sites, while at other sites the disease continues to remain controlled. And if you look at this paper by Brian O'Sullivan's group in cancer, you realize that this is what they describe as locoregional disease, oligometastatic disease, synchronous, oligorecurrence, metachronous, which means the metastatic disease has come up after control or after completion of treatment of the locoregional site. Oligoprogression, that means at certain sites there is progression of disease, but this progression is in less number of sites, and of course widespread metastasis. Now, we need to understand the problem that we have at hand and whether we need to deal with this problem. So this is again another study from Thomas Beckham. He looked at 186 patients. And what they found that with limited metastatic disease, it is worthwhile treating this disease because some of these patients, after successful control of their disease, may actually go on to live for a long time. So you have to understand that there are some patients which today we have very crude methods of identifying who may benefit with treatment of their metastatic disease. And if you look at this, it is actually a function of the disease site, the organ, whether it is multiple, single, what are the sites within the head and neck that benefit from this metastasis directed treatment, whether it is in the lung only, lymph nodes only. And then based on that, they have come to the conclusion that it would be worthwhile treating these metastatic sites. Now, we also need to understand that amongst these patients, even whether it is polymetastasis or oligometastasis, we need to understand what is the prognostic impact. And from these various, again, there are several papers in literature, a few that I'm quoting here. From this paper from Bollig, you see that both the metastatic pattern and the site of distant metastasis impact the overall survival. Polymetastatic disease and bone mets are associated with the worst prognosis independent of the treatment received. Similarly, there is another paper which by Wiesman, which talks about patients who would benefit from radical local treatment of all tumor sites. So these are patients who have a good performance status, absence of brain and bone metastasis, and low tumor volume. And these are factors that we usually keep in mind when selecting whether we want to treat a patient with metastatic disease or not. So what are the principles of management? The goal of treatment is usually to alleviate symptoms, improve survival, and maintain quality of life. Treatment plans are personalized depending on the performance status, the histology, metastatic status, and needs a multidisciplinary approach. Options available include local ablative therapies, which may be surgery, radiotherapy, and of course, the systemic therapy, which remains the backbone of treatment in most cases. Newer therapeutic options in the form of immunotherapy has significantly improved survival. And of course, today we also have newer combination therapies like a combination of immunotherapy and local ablative therapies. So what are the factors that determine treatment? Patient related, it would be the age, comorbidities, symptoms, patient's preference, the performance status, the disease-free interval, and the organ dysfunction. Tumor related would be the number of lesions, the sites of the lesions, whether they're HPV positive or EBV positive cancers. The disease-free interval has been mentioned here again because it is also tumor related, and the status of the index disease. You definitely would not want to treat a patient who has a loco-regional persistent disease aggressively if the patient were to develop metastatic disease. And treatment related, of course, includes resource availability, affordability, feasibility, safety of treatment, and expertise available. So what do you do in the workup? Clinical history, details, and tolerance to prior therapy is very important when you're taking the clinical history in addition to the other things that you would record on clinical history, a detailed evaluation, repeat biopsy. And in that biopsy, I think it would be also important to today at least look at the PDL1 score, look at blood samples for various other molecular markers. Then in the imaging, we would look at both systemic disease as well as locoregional disease. And the extent to which you would image a patient would be defined by the performance status, the extent of disease, the disease-free interval, and the functional reserve. All these points essentially pointing to the fact that you would consider doing extensive imaging only if you were considering a patient for radical intent therapy. Counseling a patient and the patient's family is very important, rehabilitation, and of course, what is the present status related to his habits. And most importantly, all these patients have to be evaluated in a multidisciplinary clinic. Now, coming to the first set of metastatic disease, that is oligometastatic disease. It is an intermediate disease state between local and widespread metastasis. It often has a relatively indolent course compared to widespread dissemination. Initially described by Hellman and Weichselbaum in 1995 as a concept of a state of limited number of metastatic lesions confined to a single or limited number of organs. It is widely accepted as less than or equal to 5 clinically detectable lesions. So today there is also a movement to again distinguish between this 5, and here less than 3, more than 3, of course, has a different clinical behavior, and hence many trials today take oligometastatic disease as typically lesions less than or equal to 3 or more than 3 to 10. Then treatment intensification with aggressive local ablation of metastatic sites may lead to long-term disease control or prolonged survival. Now, in head and neck cancer, there is limited data. It has increased because of better imaging. Then solitary mets, however, account for only 15 to 20%, and oligometastasis seen in about 30 to 40% of the metastatic cases. And several studies have shown improved survival in oligometastatic head and neck cancer as compared to patients who have progressive or polymetastatic disease. How do you manage these patients? You have various local ablative therapies, and these include surgery, radiotherapy, or other interventional ablative techniques, which is something again that is evolving in today's day and age. Historically, surgical resection used to address limited metastasis, less invasive surgery, more conformal radiotherapy, but of course it is also a function of the location, number, and volume of disease. Now you have to understand that even if it is oligometastatic disease, but the volume of the disease is large, these patients may not do as well as small volume disease. Essentially, the cutoff has been put as 3 centimeter cube. Now, SABR, that is stereotactic ablative body radio surgery, is viable, less invasive alternative option with encouraging retrospective data. And of course, these local ablative therapies may be combined with systemic therapy. And in today's day and age, there is a lot of work going on combination of these techniques with either targeted therapies like cetuximab or immunotherapeutic agents in an attempt to actually improve the local control of these metastatic lesions and also give the systemic background that is necessary so that they do not spread or become polymetastatic disease. So these are a group of studies that have been done with surgical metastatic disease. And you can see that the meta-analysis done by Young actually is the largest, which has about 403 patients. And if you go through these metastasis, this particular paper, you will see that there were 47 studies with 403 patients, and what they identified as the best prognostic parameters were essentially patients with a female gender who had a longer disease-free interval, There was no lymph node metastasis at the diagnosis of the original tumor. The sites were other than oral cavity. The metastasis could be resected completely. And of course, if the patient had multiple pulmonary nodules, they did worse. And yes, the local control could be as low as 4% to as high as almost 35%. So, but all this you have to remember is a function of all these poor prognostic factors also, which they highlighted. Now, what is stereotactic ablative body radiotherapy? It's a highly conformal form of radiotherapy. You actually conform the radiation doses to the metastatic site as against conventional principles of treatment of metastasis. You deliver a very high dose of radiotherapy, essentially more than 5 gray, using a smaller number of radiotherapy function or using a smaller number of radiotherapy fractions. And because we are doing all this, that is, we're delivering a higher dose per fraction, we are being very conformal and tight. We have to take recourse to IGRT, which means image guidance during the delivery of radiotherapy. And this has shown to have excellent local control rates of the metastasis with less than 5 to 10% risk of more than grade 3 toxicities. So this is one of the most often quoted trial, though this is not a trial that looked at head neck metastatic disease alone. This is a study that actually set the stage for looking at doing SABR-like treatments for oligometastatic disease. 99 patients, phase 2 randomized trial, 1:2 randomization, palliative chemotherapy versus palliative chemotherapy plus SABR. Primary endpoint was overall survival. If you see, as expected, the commonest sites included were, of course, colorectal, lung, breast, which are the sites that are notorious for metastatic disease. But at the same time, they did have a few head and neck cancers also. And what they found was that the patients who received SABR did better than patients who received only standard of care, that is palliative chemotherapy, both in terms of the overall survival and progression-free survival. The other thing that you also have to understand that SABR did not result in a decrement in quality of life and no new safety signals were apparent. So the authors have now actually gone on to actually have the SABR 3 and the SABR 10, depending upon the number of metastases and of course the inclusion of other adjuncts of therapy. Now, this is a retrospective analysis of patients in head and neck cancer alone. And what you can see, they had only about 82 patients, but what you can see that the local regional control rates and overall survival rates were pretty good in patients who had received ablative radiotherapy, and the outcomes are actually comparable to pulmonary metastatectomy. No more than grade 3 toxicities were observed. And of course, patients with polymetastatic disease and squamous histology fared worse. And this is something in common with the earlier results that I have shown you about prognostic factors. Now, this is a table from the same paper review article written by Dominic Moon and David Scher. And you will realize that if you look at cross, what is the kind of treatment versus the outcomes, it is mostly a function of the kind of disease that has been chosen to be treated as oligometastatic disease, the treatment that has been chosen for these patients. And if you look at this study by Sean McBride, I'll be coming to that study, you'll see that there seems to be some point in combining immunotherapeutic agents. But at the same time, we need to remember that when we combine toxic therapies, we also need to see whether they give any additional advantage. And what is quite obvious from this is that there may be some survival benefit, progression-free survival benefit, but this is not statistically significant. And of course, the very basis that we think stereotactic radiotherapy may also cause an abscopal effect does not happen. The other thing, of course, study is from PASILIC, which is a study on SABR. Now, these are some other studies also which have looked at doing SABR or combining SABR with systemic therapy. And of course, they show us similar control rates. And they also show that perhaps with high intensity local treatments, that means like SABR, we can improve outcomes in these patients with metastatic disease. So this is the study that I was talking about. That is the study as examining whether there is an abscopal effect of SABR with immunotherapy. And this study from Sean McBride with 62 patients shows that there is no improvement in response and no evidence of an abscopal effect with the addition of SBRT to nivolumab in unselected patients, though there seems to be some amount of gain in overall in our progression-free survival. Now, what do we know then for the treatment of oligometastatic disease? There's a promising role of metastasis directed local ablative therapy. Surgical resection has historically been the choice, but today we also have, or perhaps a better choice, which is non-interventional, which we don't actually have to what you call it as non-interventional, and that is SABR. And this can be combined with immunotherapeutic or systemic agents to improve outcomes. There is no role of SBRT as an immunomodulatory therapy. Now you need to understand one is enhancement of effect and one is immunomodulatory effect. That is, you're trying to see whether combining SBRT with some kind of systemic agent would help improve overall survival. That mostly does not happen, but it improves the efficacy of that of SBRT locally and perhaps may also prolong the outcomes of control. So this is one of the proposed algorithms as to what you can do with metastatic disease depending upon the number, as I was telling you. So traditionally it has been defined as 5. Today we've realized that perhaps 3 may be the more useful or pragmatic cutoff, because patients who have less than or equal to 3 metastasis seem to be doing better than those who have more than 3 metastasis, and this could be one of the algorithms. These are the various ongoing studies which are looking at combining SABR with various kinds of systemic therapy or systemic therapy alone. Now, this is one study which perhaps may throw some light on patients actually who have oligometastatic squamous cell carcinoma, and perhaps it will tell us whether we should be using systemic therapy alone or combining systemic therapy with concurrent loco-regional therapy also. So you need to, this will be an important study that we'll be looking forward for the results to. Now, what is oligoprogression? As I've already told you, oligoprogression simply means that certain parts of the disease that have been metastatic will progress while certain parts of the disease that have been treated will remain controlled. And this essentially owes itself to the fact that the tumor is heterogeneous, making certain resistant clones progress, whereas the clones that were sensitive have responded to the therapy. Now, how do you manage polymetastatic disease? This is a chart from the ESMO guidelines, and you can realize that they have classified it into patients who have never received platinum-based chemotherapy in the last 6 months, and they are PD-L1 positive, or there is no platinum during the last 6 months, and PD-L1 assessment has not been carried out. No platinum received chemotherapy and PD-L1 negative tumor. That means it's less than 1. And pre-treated with platinum within the last 6 months, but immunotherapy naive, pre-treated with platinum within the last 6 months, and with prior immunotherapy. So then you have to look at all these things and then decide on which would be the best. But definitely with no chemotherapy exposure in the past 6 months, you could either, in today's day and age, when the patient can afford and the patient is PD-L1 positive, probably start with immunotherapy. The other options, of course, are an extreme-like regime. The other thing, if it is no platinum thing, but then PD-L1 has not been started, you could start with Pembro, but depending on the response, decide what you want to do. There is no platinum, but PD-L negative, then you start with an extreme-like regime. Treated with platinum-based chemotherapy within the last 6 months, but immunotherapy naive, you could start with nivolumab. Pre-treated with platinum and have received some form of chemo, then you could start with, and some form of immunotherapy, you could start with taxanes or methotrexate, or consider the patient for best supportive care. But remember, when you do anything like this for this group of patients, you always have to keep in mind the principles of the approach to metastatic disease that I have talked about before. That is, you look at the patient factors, you look at the disease-related factors, you look at the amenities available for treatment, and then in addition to the points that are there in the first row, you will then decide on what therapy a patient can afford or should be given. Now, this is the schema just to make it more clear. So if you have a PD-L1 and a CPS score less than 1, you usually choose, and if the patient is otherwise not had any exposure, you would choose a patient to receive an extreme-like regime. But or sometimes if it is not possible to do, you could use immunotherapeutic agents, understanding fully well that if the CPS score is less than 1, unlikely that the patient is going to respond. If it is between 1 and 19, you would use a combination of pembro plus thing what you call extreme, and if it is more than 20, you would then use pembrolizumab as your first point of treatment. So this is something that you have to keep in mind, especially today when we are talking about metastatic disease. Now, coming to palliative chemotherapy, historically, palliative chemotherapy has been the standard of care. They were classified into two groups. That is, patients who were sensitive to cisplatinum. Essentially, they have received no prior exposure to cisplatinum in the before the last 6 months, or they are cisplatinum resistant. That means they've received cisplatinum within the last 6 months. In the cisplatinum sensitive group, you can try an extreme like regime. That means these are patients who have not received cisplatinum in the last 6 months or who have never received chemotherapy. Or in some patients, especially in TMH, what we have tried and what has been an alternative effective option is, of course, that we use triple metronomic chemotherapy, that is erlotinib, methotrexate, and celecoxib. Now, this is the extreme trial. I won't be going into detail because of want of time, but you have to understand that this was one of the most effective regimes in recent times that gave a median overall survival of almost 10.1 months compared to the standard of care that was 7.4 months. And this was what was the standard of care for metastatic disease, especially polymetastatic disease, that was cisplatinum naive. And this was before we had the immunotherapy regimes coming up. In addition, in patients who were possibly not candidates for cisplatinum or could be given cisplatinum in a very controlled or limited way, low-cost metronomic chemotherapy was another very effective option. And this is a study from TMH which shows that it was non-inferior to intravenous cisplatinum if that was considered as the agent to treat in the polymetastatic setting. Today, of course, we have to be aware of immunotherapy, and they were first approved for the treatment with refractory head and neck squamous carcinomas and later as a first-line therapy. For this, to date, the best marker is, of course, to do the PDL1 score. And this is important because these being expensive molecules, it is also essential for us to identify those patients who would benefit with this therapy rather than giving it indiscriminately to all. So hence, it is important for us to estimate the PDL1 score also. And this is just a diagram showing you what we call as how we calculate the PDL1 scores. So this is a study that I think all of you should be familiar with, and which actually set the stage for using pembrolizumab-based immunotherapy as the first-line therapy for patients with recurrent or metastatic squamous cell carcinoma. And I'm sure all of you are aware of what the design was, either pembrolizumab monotherapy, pembrolizumab with chemotherapy, or the extreme-like regime. And you have to understand that the maximum benefit was seen in patients who had a PDL1 score of above 1 at least. Above 20, you had the best results. You could give pembrolizumab monotherapy. Between 1 to 19, it was pembrolizumab plus chemotherapy. And in patients who had less than 1, it had to be the extreme regime. The other thing that we need to also understand that though a lot of our patients may have positive PDL1 scores, at the same time, they may not be able to afford, or accessibility may be an issue in our patients. And this study from the TMH is very important because low-dose immunotherapy could be considered as an effective option for palliation in patients with recurrent metastatic disease. And the dose that was used was a 20 milligram flat dose, plus using this way of treatment for multiple patients at the same time. It means it addresses the issue of affordability as well as accessibility, and we see that the results are positive and they are in favor of the low-dose immunotherapy arm. The other thing, of course, you have to understand is that this is again the ASCO guidelines for 2022 for the use of how do we treat patients with recurrent metastatic head and neck cancers. Please understand here that for nasopharyngeal cancers, things are a little different as compared to the other head and neck cancers. And in nasopharyngeal cancers, you have toripalimab, pembrolizumab, which have been found to be effective while compared to pembrolizumab. Now, role of locoregional treatment in synchronously metastatic head and neck cancers. This evidence is overwhelmingly positive for patients with oligometastatic synchronous nasopharyngeal cancers. We have two phase 2 trials. This is one phase 2 trial, 176 patients. Patients were randomized to receive either radiotherapy to the high risk PTV or receive only systemic therapy. And what they found was the patients who received loco-regional therapy actually fared much better than patients who did not receive the loco-regional therapy. And there were fewer distant metastatic recurrences in the CTRT group. However, can consolidative radiotherapy to the metastatic sites further improve outcomes? We really don't have any trial to address this issue. Less number sites can be treated with consolidative RT and can possibly further improve durable long-term disease control. This consolidative radiotherapy to metastatic sites can be given along with loco-regional RT and is usually given with high precision hyperfractionated radiotherapy, something like SEBA, and warrants a study to determine the role to metastatic disease. So though we have these two randomized trials, they have not evaluated the role of giving radiotherapy to the metastatic sites. Is there any role? Then what about other head and neck cancers? Again, what we see is that it may be beneficial, but we really do not know the answer as of now. And we need to look into more studies, larger number of patients, to look at seeing whether this would in any way help in patients who have oligometastatic head and neck cancer. So this definitely is the graph for it. It's, if at best you may call it perhaps hypothesis generating, but we'll have to look at it. And what about the management of bone metastasis? Now, these following slides are actually pertaining to a few specific sites like bone metastasis. We need to understand about 50 to 80% of patients, especially with cancers like the nasopharynx, and 2 to 22% in non-nasopharyngeal squamous carcinomas present with bone mets. They may cause pain and skeletal related events, which include spinal cord compression, fracture, or recurring urgent interventions. They need multidisciplinary approach. That means here again you have to have the orthopedic surgeon also on board in addition to the head and neck oncologist. The clinical assessment should look at what is the symptom, the site, what are the signs that you have, whether there is any referred pain. Blood investigations essentially should cover other than your routine blood investigations, serum, calcium, alkaline phosphatase. And an MRI is useful in assessing infiltration of the thecal sac, spinal cord, nerve roots, etc. And so then there are two concepts here. You have to look at complicated and uncomplicated bony metastasis. Uncomplicated bony metastasis, essentially they only cause pain without impending or existing pathologic fracture or without spinal cord or cauda equina compression. That means there is no anatomical impact of this bone metastasis as of now. So it is uncomplicated. Usually radiotherapy is the standard of care and it can achieve significant pain response in almost about 80% with a median duration of about 18 to 21 months. So if you look at this particular update of the systemic review, overall response rate similar in patients for single fraction versus multiple fractions. And of course, what we also need to understand, because this becomes an important question, that when you send a patient to us with multiple bony metastasis, whether we should be treating it with a single fraction or multiple fraction. So the normal dictum is that from all the evidence, so this is one paper, then you also have this paper, that you can do single fraction, because what happens is single fraction is easy to use, it is affordable, and from the patient point of view, it is also effective. The other thing is that there is no evidence to suggest otherwise. That means there is no evidence to suggest that perhaps giving a single fraction is inferior to multifractionated radiotherapy. So these are the considerations that you need to keep in mind, and especially if they are uncomplicated bone metastasis. Then you have the entity of spinal cord compression. You have to understand that most often it is thoracic, followed by lumbosacral and then cervical. Obviously, it is also because of the extent of the spine in these places. It may be subclinical or accompanied by neurological symptoms. Prognosis depends on the performance status, neurological status, histology, status of primary disease, and we prefer to do an MRI in addition to whatever other imaging may have been done. And this is the Bilski rating system. Depending upon the involvement of the MRI, how much of the vertebral body has been involved in relation to the spinal cord. And this is one of the algorithms looking at how they can be managed. So essentially you have to we start with steroids. We also have to stabilize the spine. If the spine is stable, there is no cord compression, probably you could go ahead with radiotherapy. But if there is an impending cord compression, spine is not stable, it would be best to stabilize the spine followed by radiotherapy. Now, this is the SCORAD randomized trial, which looks at single fraction versus multiple fractions, and you can realize that there is actually no difference between the two at different, and it is non-inferior, especially in ambulatory patients. Again, this is a meta-analysis. There is no evidence of an observed difference with respect to motor thing, bladder dysfunction, overall survival between single fraction and multi-fraction in patients with metastatic cord compression with a limited prognosis. So these are the guidelines for management of patients with complicated bone metastasis. Now this is what you either have impending fracture, you have a collapse compression, and re-radiation rates may be slightly higher with the use of a single fraction, but in these patients it may be preferable to use multifractionated radiotherapy regimes. Okay, then comes the neuropathic pain. Again, I will not spend too much time, but you need to understand what it is. And radiotherapy again can be effective in this situation also, but with the use of various other adjuncts like gabapentin, pregabalin, and tricyclic antidepressants. Pathological fracture, you have to understand that this is a setting where radiotherapy is useful. But because there is a fracture, it essentially also again calls into light the fact that the orthopedic surgeon has to be involved, and we have to stabilize the fracture before going ahead with radiation therapy. This is the Mirror scoring for long bones depending upon the location, radiologic appearance, size, and pain. And it is important for us to understand that, of course, an orthopedic surgeon has to be involved in the management of this metastasis. Also, spinal instability, again, you have the SIN score. Now, you realize from this paper by Patchell that though we talk about radiotherapy being very effective, however, patients in where it is indicated, especially when the prognosis is not poor, it may be better to actually first do decompressive surgery and then follow it up with adjuvant radiotherapy. The outcomes are much better in those patients. Now, local treatment for impending fracture, of course, I've talked about surgery. You also have to give post-operative radiotherapy. But in patients who have poor performance status and limited life expectancy, radiotherapy alone may be chosen. In bone metastasis, we've already talked about SBRT right in the beginning when we talked about limited or oligometastatic disease. This remains the same even for this patient. Now, this is a study that is looking at this is the first study by Arjun Sehgal, which talked at stereotactic body radiotherapy versus conventional radiotherapy. And this actually set the stage for doing stereotactic radiotherapy in patients who had metastasis, oligometastatic disease. And they actually what you call looked at two fractionation regimes, conventional RT in 20 gray per in 5 fractions versus SABR. And they found that actually there was no treatment related deaths in either arm, and SBRT was superior in controlling the disease as compared to conventional radiotherapy. So this is the workflow. You have your pre-treatment assessments, and then you have what you need to do, and then how do you treat this patient, and then of course follow up. We also need to understand when we're discussing the approach to metastatic disease that various other non-surgical options have been described today, and they include various non-interventional radiology related procedures like radiofrequency ablation, balloon kyphoplasty, percutaneous vertebroplasty, and even ablation. But of course, we do not have any metastatic evidence, but they have been proven to be useful in the treatment of bone metastasis by either injecting the involved bone or the involved vertebrae mostly with cement and also trying to stabilize vertebral fractures. However, we do not, times are still a little early, or it is a little premature for us to say whether these alone can be the only treatment in long term for these patients with bony metastasis. Supportive care is very essential. aims at to improve quality of life, and these include pain management, nutritional support, psychosocial support, palliative care, and symptom management. Very important to understand in these patients. Pain management, all of us have to remember, cannot forget. And of course, I won't go into details, but we need to know the WHO's ladder, and perhaps today with a little bit of modifications in this ladder that has been suggested. So in conclusion, management of metastatic head and neck cancer involves a multidisciplinary and individualized approach. Goal of treatment is to reduce symptoms, improve survival and quality of life. Dictated by site, load and volume of metastasis, systemic therapy remains the backbone. Phase 3 randomized clinical trial data suggests the role of locoregional treatment in selected patients of de novo, especially metastatic nasopharyngeal cancer. Metastatic directed therapy has a role in oligometastatic disease and palliation. Ultimately, supportive care plays a crucial role, and the landscape of management is ever evolving because today we have so many immunotherapeutic modulation that is happening. We have trials that are ongoing to look at these approaches. And the other thing that we also have to remember is that when we look at this, we need to understand that it is not something that is static. It is something that is ever evolving because the disease is also ever evolving. We did not have the concept of treating metastatic head and neck cancers. We would write them off as palliative. We would not pursue these patients, but today things have changed. And this is in part responsible. And the reasons for this actually are the fact that we understand the disease somewhat better. We have better modalities to pick up these diseases, and perhaps in the final run understand that if we were to treat this metastatic disease, especially in patients who have limited or oligometastatic disease with locoregionally controlled index primary, we could possibly extend not only the disease-free survival, and perhaps in some patients also look at improving their overall survival. Also, you have to remember that today is the day and age where we are looking at various molecular markers. In addition to the prognostic factors, we're trying to look at various molecular markers that may help identify patients who are at higher risk for metastatic disease, or even at follow-up, identify those patients who may come back with metastatic disease. So in the virus-related cancers, like nasopharyngeal cancers, we have EBV titers. Even in HPV, we have whether there is the HPV DNA still circulating in the blood. For other tumors, for other head and neck cancers, we also have circulating chromatin and things like that, which are evolving and which I'm sure in the times to come will replace our other clinical methods of identifying patients. Thank you very much for a patient hearing. I'll be happy to answer any questions, and I acknowledge the help offered by Samarpita in preparing a whole lot of these slides, and to Anuj also, and the entire head and neck radiation oncology group. Thank you very much. Thank you, Poonam, for this opportunity to talk on this topic. Thank you.
Thank you so much, ma'am. Actually, I thank you a lot that you took time from your busy schedule. Thank you so much, madam. Madam, only one question I wanted to ask you you have already explained all the important points that in our routine practice, because most of the time, especially in the surgical clinic, nasopharyngeal cancers, we know they are very good cancers. Usually, with even with metastasis, we'll be treating them with quite aggressively. Same is for many a times adenoid cystic carcinomas. But what about, madam, squamous carcinomas? So, like situations where one.
So that's a very pertinent question, especially since most of our cancers are non-metastatic, are non-nasopharyngeal cancers. So if you saw, there was only one article that I showed you where it shows there is some possible utility to chasing oligometastatic squamous carcinoma, and this is today the case simply because you have got effective fallback strategies, which means that they need not necessarily be local or loco-regional, but we could use effective systemic agents, especially in the form of immunotherapeutic agents. But yes, if a squamous carcinoma who is otherwise loco-regionally controlled today comes to be with oligometastatic disease with a disease-free interval of say more than 2 years, I may still consider this patient for radical intent therapy unless I have evidence to say otherwise. The reason being that this patient has otherwise high risk, but still remains locoregionally controlled by whatever detectable methods of detection we have at hand. So it may be worthwhile treating the metastatic site aggressively, especially if that site is amenable to any form of metastatectomy or stereotactic ablative body radiotherapy. And then, of course, follow it up with doing immunotherapy. Now, I cannot answer this question whether we should wait for the patient to become symptomatic or throw more meds and then start systemic therapy, because this question, if you ask me, is a little ironical. If this patient is asymptomatic, that means the volume or the load of disease is small, and I sometimes feel it may be the best time to actually do something to the disease rather than wait for it to progress and make the patient symptomatic. Also, because if the patient can afford immunotherapy, we do realize that these therapeutic strategies, unlike conventional chemotherapy strategies, are not as toxic. And patients who can tolerate and afford, I think, may be given this chance upfront.
Right, ma'am. Ma'am, what cutoff usually you take with your this vast experience you have seen, that what cutoff you take for your oligometastasis? You said five, usually less than five. Some we saw less than three also. So, or size also matters. Like lung has three metastasis, bone
Yeah.
has. Does it
So
matter?
you're very correct, Poonam, because if you see the traditional definition which was suggested by Helvey and Wishel's mom was actually five. But if you see now after the Cyber 2, what has emerged is that maybe patients who have less than three metastatic disease, many sites of metastasis or oligomets, may actually do better than patients who have 3 to 10. So that's why you have the two other randomized trials, that is the Saber 3 and the Saber 10, which are trying to address this question. There is also this issue about the location of the metastasis. It may be a single metastasis, but it may not be amenable to either it's a central lung lesion or a central, essentially a central lung lesion. So now actually the boundaries of doing Saber have also extended into this no-fly zone, as they call it in the lung, that is central metastatic disease, and they have actually gone on to consider larger dose per fraction of almost 12 to 20 gray. So actually today nothing is beyond treatment, but at the same time we have to be very cautious, because even if you see the Saber 2 Comet, Saber 2 trial, Saber Comet 2 trial, what you realize is that there is a death of almost mortality of about almost 4.5%. So every attempt should be made to see that our toxicity because of therapy is not so high. So we will try to treat. It is 3, 5. It is important for us to understand the size, the location, and the volume. Because if they're large mets, we may not be able to treat them curatively. But having said so, I would say that we would still make an attempt to treat these patients. We may not treat with Saber like regimes. We may treat with a slightly lower dose per fraction, but we will try to treat. The simple reason being that even if they are large volume, we will still give good palliation to these patients and then following it up with systemic therapy.
Correct. So I think the message here is that even if it is coming in a surgical clinic, there is distant metastasis. It is important still to do the multidisciplinary this approach here also. Take opinion from the radiation oncologist, take opinion from the medical oncologist and the palliative care, and then take the final call. Ma'am, there is one question I think on the chat box. I think in fact there are two, three questions. Flow chart of management of progression. Someone has asked for the slide, madam. I think we'll go to the next
Yeah, I
question.
just show that slide, but yeah, we'll go to the next.
So
We'll
how
go to
to
the
manage,
next question in the
right, ma'am. How to manage the case of very advanced oral cavity cancer, which is undergone extensive resection, and uh, or before getting adjuvant or during adjuvant treatment develop skin metastasis in form of nodule around the primary resection and neck site. So, ma'am,
See, such a case, no, I wouldn't think is worthy of actually being treated very radically. Your attempt at treatment, your intent of treatment should then become palliation. And the simple reason is that here biology is telling you how to take care of the disease. Now, if you see this disease, essentially what is happening is the patient is on therapy And despite being on therapy, the patient is developing skin nodules. Now, skin nodules are both a sign of distant metastasis because they have come back in the site, as well as locoregional disease, simply because skin, if it is beyond what you have resected, is definitely distant metastasis. And in the site that you have treated, if it has come back, definitely again, it means it is metastatic disease. It is a disease that has failed all your treatment. So I think in this patient, it would be best to stop your locoregional therapy and consider this patient for some form of systemic therapy if the patient is suitable for it. But many medical oncologists may not want to treat such a patient, saying that this is a patient who is not going to do well. But you may want to consider therapy right now if the patient is systemic and is symptomatic and has multiple skin nodules. But I will definitely want to stop all locoregional therapy. Is this the thing that you were talking about, the slide? Somebody had asked for the slide,
Yes,
right?
ma'am. They want to know about the oligo progression, madam. I think there was,
Okay.
yes, ma'am,
Okay. Yeah.
on the oligometastasis, probably.
See, you have to, I don't remember which other slide I had shown for, there
Slide
were two.
flow start of management of oligo progression. I think there was one slide on the oligo progression.
Okay. Is there any other question? Then,
Yes,
yeah, I
there is
think this one.
I think
Recurrent
this.
or metastatic? And then there was this one.
So when do we
Because
call
this
it?
is the only flow chart. No, so if you could tell me what is the question that you're wanting to ask, or I could tell you what reference to look up.
The question is the chart, I think, flow start of management of oligo progression. That was the only thing they have written.
Okay, I don't know. Anyway, we can't find. Then there is another question: patient with distant metastasis but with poor PS. Can you highlight which is the preferred? See, as I told you, the intent of any therapy for a patient with metastatic disease is essentially to direct the symptoms, direct it towards the symptoms of the patient. Especially if the performance status of the patient is poor, I would then look at only doing best supportive care. If the patient's performance status is poor because of pain and he's got a painful bony metastasis, I would treat that painful bony metastasis with radiotherapy and give supportive therapy like any kind of painkiller. But if the PS is poor because he's got progressive disease, he's got polymetastatic disease, then the best treatment would be just to do supportive care and nothing more.
Right, madam. Madam, one more question is there. What will be the modality of treatment for a post-operative oral carcinoma of 1 year who presented with a cervical as well as distant metastasis in lung?
Okay, now see, in this case, there are two questions. One is the DFI is just about 1 year, and if this was a high risk patient to begin with, this is expected because most failures occur within the first 18 months itself of since therapy. So if that is the case, you would have to see what is the volume of metastatic disease. And now for head and neck cancer, that is the non-nasopharyngeal head and neck cancer, you have very limited data. Whether you would, now supposing that is the only site of metastasis in the neck, you have only one deposit in the lung which is resectable, the nodal metastasis is resectable, you may perhaps want to do resection at both sides, provided both the resections are non-morbid and the patient is young, patient's performance status is good. But remember, today I'm telling you all this from no evidence. I'm telling you from just practical, from experience. But at the same time, you may also want to think about systemic therapy in this patient.
Right. There's one more question, madam. As per your experience, how long should we continue immunotherapy if the patient had good response with SABR for lung metastasis?
See, the thing is that immunotherapy, once you have started, the dictum of immunotherapy is continue it till there is response and there are no what you call side effects or sequelae to therapy. That is the basis of immunotherapy. But minimally, people continue it at least for 24 months, especially in the patients who are responding to immunotherapy. So that is the other side of immunotherapy, that the answer to when to stop immunotherapy is only based on this thing. That is, there is no progression and that there is no side effect of therapy. There is no other criteria to stop immunotherapy as of today.
Right. So I think these are the questions, madam. So if there are no more questions, we can conclude today's lecture. I thank you once again, madam. A great lecture. I think no need to say that. So thank you so much, madam.
My pleasure. Thank you, Poonam, for the invitation. Thanks a lot. Thanks to all the people who joined in. Bye. Have a great weekend.